This is the Week 2 presentation for Veterinary Anesthesia and Surgical Assistance 2. For Week 2, you should read Chapter 2, Patient Preparation, and the Thomas and Lerche text, pages 5 to 27. The chapter begins with the basic outline of what you're going to be reading. It then has on the left side of page 5 key terms, and it's always important to understand the terms. And then it goes into the learning objectives for week 2 and chapter 2, patient preparation. The very first full sentence of chapter 2 says that all anesthetic procedures begin with careful patient preparation. Well, I'm going to change that. And I'm going to tell you that all successful anesthetic procedures begin with careful patient and staff preparation. Everybody has to be organized, everybody has to be on the same page, there has to be good communication, and the staff have to have their heads into the anesthetic procedure that's coming up. That means that you're not going to be talking about what you're having for lunch, what happened on Grey's Anatomy, who got a new car, that kind of stuff. You need to pay attention and really focus on any anesthetic procedure. It's almost like being a professional athlete. You got to get your game head on, you got to get your game face on, you got to get your head in the game, and then when the game's over, when the anesthetic procedure's over, then you can go back to worrying about other things. There's a lot of things you can do in practice, like blood work or perhaps even taking an x-ray, where you can kind of, let your mind wander, talk to people, have a running conversation, catch up on the gossip. But when it comes to anesthesia, you need to really be paying attention to that all the time, the whole time. Because if you don't, that's when something bad is going to happen. As we get into Chapter 2, one of the first things the authors present you is Box 2-1 on page 6, patient preparation, the to-do list. If you don't have a to-do list, or if you don't even have one in your head, that's a good box to make a copy of or put it in a Word document and print it. It gives you a good idea of what you need to be doing to be getting ready for any anesthetic procedure. Even if you don't actually do the patient preparation, to have it available to remind people is a good idea. And certainly if you did it in Microsoft Word, kept it around, you could edit it, you could add things, you could delete things based on the particular circumstances of your practice. On Chapter 2, page 6, communication, a key to success. Certainly if we're not communicating well in the peri-anesthetic period, there are going to be problems. You have to talk, you have to communicate, you have to be upfront with people about what you're going to be doing and how you're going to be doing it. And then finally, over on page 7, case 2-1, a case presentation. The poor guy that has the dog that has all his teeth pulled, and the owner is not happy, and it gives an example of poor communication. I think we've all been in situations like that. I guess most of us, after reading that, I know I'm saying to myself, well, it doesn't matter how much you communicate with some people, they're still going to be mad. If you tell them, I'm going to have to pull 47 of your dog's teeth, they come back and you've pulled 47 of the dog's teeth, they're still mad because their dog doesn't have any teeth left. And you told them you're going to pull all the teeth, but I guess they just can't visualize their dog without teeth, and that's when you give them the card for doggy dentures, 1-800, call for teeth. We try to communicate the best we can, get everything we can in writing, and then on the basis of that we move forward. We'll be covering things in both the Bush text and the Thomas and Lerche text that overlap each other. We've covered minimum database in the Bush text, and now we're going to cover the minimum database in the Thomas and Lerche text. Page 8, it gives you the criteria, and pay attention to that for a minimum database. There's a good test question in there, I guarantee you. Then it talks about the importance of patient history. When we do patient histories, it's important to get a good patient history. It's important to ask the right kinds of questions. It's important to really get a good history, because you'll be amazed how much information owners will withhold from you. We have to confirm the scheduled procedure. Obviously, we don't want people canceling, big large holes in the day, that kind of stuff. So we need to make sure that people know what's going on, and they're going to be there on time, and that we're actually going to be doing the procedure that they thought we were going to be doing. You'd be amazed how many times people show up for tumor removal when we thought we were going to be doing a dental prophy. So we need to make sure everyone, again, communication is on the same schedule for what we're going to be doing on that particular patient. Then the chapter gets into how to obtain a patient history. More important things, gets into what a signalment is, and you certainly need to know what constitutes the signalment. We also get into specific of species, breed, age, sex, and reproductive status of that patient. Species will play, as you will find, a very, very major role in doing anesthetic procedures. I had an anesthesiologist tell me in a seminar one time that all anesthesia is the same, yet no anesthetic procedures are ever the same. Species is one major consideration, and pay a special attention because there's lots of test questions from page 9 about specific needs of species. How are ruminants different than horses, which are different than cats, which are different than dogs? And we're not even getting into the non-traditional species like avians or reptiles. Two good terms to know on page 9, hypercarbia and dead space. Later on, we'll be getting into the need to pre-oxygenate patients. I get a lot of questions and a lot of resistance to pre-oxygenation. And if you will pay attention to the section there on page 9 about hypercarbia and dead space, you're going to understand, and we'll later on grasp the concept of why we have to pre-oxygenate patients. Breed is going to play a role in some anesthetic procedures. Some breeds are going to have different anesthetic traits, idiosyncrasies. Age is going to be an important thing. Anybody can do anesthesia on that happy, healthy 6-month-old Labrador Retriever, but the very young and the very old, the infirm, those are going to be totally different deals. And finally, sex and reproductive status. Those are going to play a role in anesthetic procedures. It's going to get into also certain things. They talk about the use of acepromazine with horses and that kind of stuff. So pay attention to sex and reproductive status. But the ones on that page that probably are going to most profoundly affect us are going to be the species and the concept of dead space and hypercarbia. Other information that we're going to need to obtain before we do the anesthetic procedure, certainly a history of pharmaceuticals or other drugs. We need to know what they're having, when they've had it. You'd be amazed how many people have these dogs on just these absurd and wild supplements. And yet, they don't tell you about it because it's just a supplement. How hard can it be? I mean, how dangerous can be all that coumarin be in their diet? Allergies, drug reactions in the past, certainly many antibiotics these dogs can have reactions to. So we need to know what's going on with that. Are they on routine preventative care? Have they had their vaccinations? Any concurrent illness or medical problems? We may see a dog on Monday. A dog has profound periodontal disease. We schedule a dental prophy on Friday. The dog shows up on Friday, but they don't bother to tell you that in between there, they got hit by a car, or that they suddenly had 3 days diarrhea. We need to make sure that when they come in, if there have been any changes, is there anything going? We need to really need to make sure that's going on. And then other considerations your author goes into. They talk about consent forms, making sure the paperwork is done, and so on and so on. So make sure that we cover all our bases before we start injecting these drugs into these patients. On page 12, Figure 2-1, consent form. There's an example of a consent form. A lot of practices I see and talk with, their consent forms are very out of date. They're usually, often 2 or 3, 4 sentences that says, can I basically do anything to Fluffy we want to do, and you agree to it, sign here. those consent forms usually don't hold up in court. And if you're going to use consent forms, please use consent forms. Then you're going to need to have one that really does some good. And that's a good example out of the University of Pennsylvania. If you have a lawyer, an attorney who does consulting work or is on retainer for your practice, make sure they update periodically all your paperwork, and make sure there's somebody that actually know what they're looking for, that they understand what a consent form is, what it's there for, and how it can protect you. So make sure that your consent forms are up to shape. Physical exam, physical assessment, we can't overemphasize again all the things, and you can read through this. You're going to get physical exams in this class, you're going to get it in your next class, you're going to get it in nursing, you're going to get it in diseases. Physical exams are the basic unit of all of medicine, whether that's two-legged or four-legged. And if you can do a good, thorough, knowledgeable physical exam, you're going to be worth your weight in gold. Patient identification, I think that kind of goes without saying. We certainly don't want to be doing surgery or anesthetic procedures on the wrong patient. People get really upset when they show up and they give them their neutered dog, and they find out later on he was only there for boarding and that he was a $300,000 breeding machine. So make sure that you have proper forms of patient identification. You need at least two kinds, either that's cage card, neck bands, something to ensure right patient, right thing. Body weight, your book gets into body weight, figure 2-2A and 2-2B, page 15-16, shows the famous Purina body condition system. I think we've been through that enough times that I can refer you to that and you'll understand it. Weight's going to be a big consideration. Either too skinny, too fat, and you're starting to have to deal with some unique anesthetic problems. Other things I want you to pay a lot of attention to. Number one, assessment of hydration. It's on page 17, physical signs associated with dehydration, table 2-1. There's lots of test questions. You need to be able to assess quickly and accurately status of hydration. Level of consciousness. This is something we may not always be paying attention to, but we need to be doing that. We need to be assessing level of consciousness. Lots of test questions on level of consciousness, especially some of these patients that come in that may have been injured, may be very sick, may have been hit by a car, for example, and we may be doing something surgically, either a laceration repair or an orthopedic procedure, who knows what. But we need to be able to assess their level of consciousness going in and coming out and on a consistent basis after anesthesia. Pain scores, I refer you to pain score. We'll be talking more about pain later on. Certainly being able to know if the patient's in pain, how much pain, and how to alleviate the pain is going to be essential. Body temperature, general condition, all those are going to be important things to assess, either on a emergency basis for an anesthetic procedure or a routine basis for an anesthetic procedure. Sometimes we get into doing anesthetics so routinely we start to overlook the simple things. And I've heard of stories of people, dog comes in, normal dental prophy, dog wakes up, it's not doing well, take a temperature's 105. They don't know if the temperature was 105 going in or if that's something that happened during the anesthetic procedure. Maybe it was malignant hyperthermia. If you don't know before, you can't assess afterwards. Don't overlook the little things. The little things will always get you. And then the chapter gets into lots of things. Talks about gait, the movement of the patient, assessing how well they're moving, what's going on there, their temperament and activity level, examination of their exterior surfaces, exam of the eyes, ears, nose, oral cavity. In your book, on page 20, there is an excellent little chart showing pupillary light reflexes. Be sure and pay attention to the pupillary light reflexes. By checking those, sometimes you can get a real indication of what's going on in the brain if there are problems in there. So pay attention to that figure 2-3, pupillary light reflex. It's well worth spending your time on. Again, and we'll go through this over and over, we're going to go through PE, the importance of physical exams. Also remember that if this new edition of the text, the 4th edition, really emphasizes far more than previous editions the importance of physical examinations, and I think that's a very wise thing for it to do. Continuing on with the various aspects of the physical exam: cardiovascular system examination, auscultation, particularly the respiratory system, palpation of the pulse in comparison with the heart rate. You need to make sure that you have a pulse for every heartbeat. There's not a pulse deficit there. If you have a pulse deficit, that can indicate some pretty severe underlying cardiomyopathies. Assessment of mucous membrane color and capillary refill time. You need to check mucous membrane color. Certainly, are they nice and pink? Are they starting to get a little bit pale? Do they have a little bluish tint to it? Can they have a little bit of yellow tinge for some icterus? Be sure and check mucous membrane color and capillary refill time. A lot of people think capillary refill time is an indicator of blood pressure. Are they perfusing good? It's not really. All the capillary refill time really tells you is the relative difference between systolic and diastolic pressure. If there is small difference between systolic and diastolic, you'll be able to press on the mucous membranes. They will blanch. They'll pop back pink very quickly. If there is a large differential between systolic and diastolic pressures, then you'll press on that mucous membrane. It will turn pale, and it will stay pale, 2, 3, 4 seconds. That's a bad thing. It does not tell you what the overall blood pressure is. So take capillary refill time with a grain of salt. It is a good indicator of the relative difference between systolic and diastolic pressure, and therefore a very long capillary refill time can indicate a low mean arterial blood pressure, but it doesn't always. You can still have a pretty high systolic, and even if the diastolic is quite a bit lower, your mean arterial pressure can be okay. You can have a fairly low blood pressure, and if there's very little difference between systolic and diastolic, then you'll have a quick capillary refill time. Probably as you measure CRT, your most important thing will be to monitor the trends and to see if it's remaining at 1.5, 2 seconds, or if it's getting longer, or hopefully if you have a problem with the patient, it's getting better. So watch the trends on capillary refill time, but do not take it as an absolute indicator, particularly of blood pressure. Be sure and pay good attention to the respiratory system. Sometimes I've seen students that will kind of overlook the respiratory system as they go through the physical exam. They listen to the heart and they check the abdomen and they look in the eyes. Make sure you really listen to those lungs well. Get a good indicator of respiratory rate. Get a good estimate of respiratory depth. Make sure that you understand the character. Is it a normal thoracic respirations? May they be trying to breathe abdominally, which might indicate some sort of respiratory problem. And listen to those lungs. Make sure that the air is moving clear, free, etc. And if it's not, then that's certainly something that's going to be a major consideration in the use of inhalant anesthetics. We're also going to, of course, want to palpate the abdominal cavity. Also stick your stethoscope on it. Listen, see if you can hear those intestines gurgling and burbling and making all those wonderful borborygmic sounds. We're also going to then move on to the pre-anesthetic diagnostic workup. Depending on what your practice's protocols are, you're going to probably be doing some degree of pre-anesthetic assessment, blood work, and other tests. Make sure that those are done in time for the patient to actually have that ready for the patient or the veterinarian so that we can formulate the anesthetic plan. And I've literally have seen people, they'll draw the blood work, do the anesthesia, and then look at the results. No, we don't do that. We have to have the results so that we can then assess the patient and come up with the best anesthetic plan for them. Things we would include CBCs, a urinalysis. I like urinalyses. I think urinalysis is a good test. Students get frustrated with urinalyses because we find so many normal urinalyses. Well, a normal test is just as valuable as an abnormal test. So if you're doing UAs and you're doing complete UAs, which includes sediments, be sure and understand that just because it comes back normal doesn't mean that it doesn't have meaning or it's of value. Blood chemistry tests, of course, a lot of us will run those. Check ALT, ASTs, serum alk phos, BUNs, creatinines, perhaps electrolytes, all that good stuff. In some dogs, cats or species, we may want to do blood coagulation screens, and we'll get into those more later on. Mucosal bleeding time tests are easy, quick, and can give us a lot of information when they're indicated. Certainly an ECG may be indicated in some of these older patients or dogs or patients with underlying cardio problems or with potential heart dysfunctions. Imaging, we probably will be wanting to take x-rays ever so often, or to do ultrasounds. And in practices where there's more sophisticated testing, certainly PET scans or MRIs may be indicated for certain things. And then there are some miscellaneous tests, and your book goes into what may constitute miscellaneous tests. You maybe want to be doing some arterial blood gases or some electrolyte studies. There's just things that you're going to start off with as a basic panel, and then as you move through the patient's history, concurrent disease, things you may be finding on other tests, you may wish to expand your pre-anesthetic blood work. One of the most important parts of this chapter, and I can guarantee you one that you're going to see on exams, not just for this week, but on major exams and probably forever from here on out, is going to be determination of the physical status of the patient. These are based on parameters set by the American Society of Anesthesiologists, and while these were developed for human anesthetic patients, they have applicability in veterinary medicine and should be used. I don't want to see any patient go to surgery without a knowledgeable and a correct ASA classification. These used to be called ASA 1, ASA 2, ASA 3. Now they're really called ASA P1, ASA P2, ASA P3, and so on. In your book on page 25, they list the various parameters, the various criteria for a P1, a P2, a P3, and so on. In human medicine, we go through P6. In veterinary medicine, we only go through P5. A P6 in human medicine is a patient that is clinically brain dead and is awaiting organ transplantation. We just don't do that in veterinary medicine. We certainly see some patients that are brain dead, but we're not commonly going to be harvesting organs for transplantation. If you're working in a major teaching hospital, that may be a consideration. Most people in private practice aren't going to be doing that sort of stuff. So understand what you're going to be getting into, and I will be asking you, this patient is this. Is it a P1, P2, P3, P4, P5, P6? You have to know that, okay, over and over and over again, and you need to use it. Get in the habit of every anesthetic record writing down whether they're a P1, a P2, a P3. If you do that, it will pay you great dividends later on. I will also, in your book, refer you back to page 22, table 2-4, where there is pre-anesthetic diagnostic test recommendations, and it tells you for dogs and cats for P1 and P2 what is the minimum database you ought to be looking at going into any anesthetic procedure. That's a good rule of thumb to follow. I think that's really a very good chart, and I like their recommendations. I think they're very spot on those. Also down there is a link to the Cleveland Clinic with more information and more specifics about the ASA P1, P2 classifications. So if you want to know more about these, how they were derived, how they're used, and that kind of stuff, then I would refer you to that website. Unfortunately, in our profession, too often everybody gets the same thing. Every patient gets whatever protocol your practice is using. I find that disheartening. Every patient should be assessed. Every patient should be treated as an individual. And just as that patient is treated as an individual if they have a skin infection or if they have a urinary tract infection, their selection of anesthetics should be made for that specific patient. We don't just have standard protocols for patients. We should have various plans for each patient based on what would best suit the needs of that particular patient for this particular procedure. Factors that are going to influence that selection, obviously facilities and equipment. If you don't have an anesthetic machine, then there's no point of even bothering to think about using inhalant anesthetics. Familiarity with the agents. The biggest determinant of safety in any anesthetic procedure is the anesthetist or anesthesiologist's familiarity with the agent. That's why we got away with rompin, ketamine, and atropine for so many years. Really a pretty awful combination. Yet, because people were familiar with it, they could predict all the bad things that were going to happen. Then they got away with using it. And did they use it successfully? Well, the patient woke up. That's about the only criteria that some people have. If you're not familiar with Domitor or Dexdomitor or dexmedetomidine, if you inject that stuff and you don't know that you're going to get heart rates down in the 40s and 50s, scare the bejeebers out of you. I know it's going to get heart rates in the 40s and 50s, and it still scares the bejeebers out of me. But if you know it's going to happen, and you can predict it's going to happen, and you can be prepared when that happens, that's going to make a huge difference for you. You need to be familiar with something besides more than one anesthetic agent, okay? You need to have a repertoire of various agents that you can use, but you also have to be familiar with them. The type of procedure that's going to be done, certainly maybe open chest procedures may dictate a different anesthetic plan than a dental prophy. The circumstances specific to the procedure, what's going on with that patient, under what circumstances are we going to be working, is there any other concurrent things that are going on, that's going to influence our choice of agent. The one factor that comes up time and again is cost, and I think that's unfortunate. Many people do make anesthetic choices based on what is absolutely the cheapest. Another reason to be used, rompin, ketamine, atropine. It is cheap, but is it the best thing for that patient? I think almost every owner I know is willing to pay a little more under most circumstances for the knowledge that knowing that their pet's going to get the best care possible. There are some drugs that a lot of people won't use simply because they're expensive. A good example, and we'll talk about it later on, is etomidate. Etomidate's an excellent drug, a fabulous ultra short induction agent, yet a lot of people are loath to use it simply because it costs more. I always ask the question, how much is a live patient worth? If we cut costs, the patient is the one that pays the price. And I would rather do what's best for that patient, pass that cost on to the owner. We, of course, communicate. We tell them, but almost everybody goes for it. Almost everybody knows that, this is better for my pet, and I'm willing to spend the extra $3 to do it. They go for it. So, be upfront with people about costs, but make the best decision for the patient, not the most cheap decision for you. The degree of urgency, is this something we can schedule later? Is this an acute emergency? Do we have to get in there and get it out now? The book goes into pre-induction patient care, and I think that's important for you to be aware of. They talk about withholding food before anesthesia. Yes, we withhold food before anesthesia. They also talk about withholding liquids, water. There is some degree of disagreement on that. I tend to not withhold water at all from anesthetic patients. The chance of regurgitation versus getting them dehydrated, it's just not worth it. Everybody has water up until the time they want to drink, then we induce them. I don't care. We just know that, and we just take care, and we're do fine with it. But again, food, we want to do that, and the classic rule is always assume every patient has already been fed a huge meal, whether the owners say they have or haven't. Has Fluffy had any food since last night? No. And I'll guarantee you about 10% of those guys or more will throw up breakfast. Well, you said Fluffy didn't have any food. Well, I think Billy may have given him some food, and Susie may have given him some scrambled eggs, and Bobby may have given him some toast, and my husband probably gave him some bacon. Just assume everybody has eaten. Treat them as if they had been eaten, and you'll do fine, okay? But don't ever trust owners. Patient stabilization, there are times when we're going to be doing surgeries. We will want to stabilize the patient, get them as stable, as out of shock as possible. Dogs that are hit by cars, cat that may have been in fights, or attacked by dogs. We get them stable, then we go in and do the anesthesia, then we fix whatever's wrong. Sometimes we don't have that luxury, and we just do the best we can. But if possible, patient stabilization is always the most desirable route to take. And that concludes the presentation for week 2 material. If you have questions, need additional information or clarification, please let me know.